Good morning, everyone. Today I have a very special privilege. It is a great pleasure for me to introduce Dr. Valentin Fuster. I've been trying to figure out what I was going to say about him that is not known by everyone, and that will not take me the entire hour. So I chose just a very few highlights. You all know that he's the chief of cardiology at Mount Sinai Heart and physician-in-chief at Mount Sinai. Also that he has been in the past president of the American Heart Association, the World Heart Federation, and he had really turned the Journal of the American College of Cardiology into a jewel, the journal with greater impact in cardiovascular medicine and one of the greatest journals in the entire medical field. I had the opportunity of meeting Dr. Fuster when I was a fellow at the MGH. He was chief of cardiology there, and he gave a lecture on the vulnerable plaque. For those of you that understand now acute coronary syndrome, I will tell you it is because of the work that Valentin did integrating basic science with clinical observations to determine that the progression of atherosclerosis was not always a linear progression that we all used to believe before him. More importantly, I should say, I had the privilege of working with him for 5 years at Mount Sinai, and I saw a side of Dr. Fuster that maybe most of you don't know. He is at heart a clinician. He is dedicated to his patients. He demonstrates compassion and dedication to clinical work as much as any other person I have ever met. In fact, I was surprised by the volume of patients that he would see day by day, and the fact that he will see and dedicate much attention to a politician, a famous artist, or a homeless person that would walk into his office. I really learned that from him because I can tell you I've never met someone who would represent better the Hippocratic Oath. And the final accolade of Dr. Fuster, which you may not know, is that the span of his reach is so wide that he has even been known in the younger generation, those who watch Sesame Street, as Dr. Rooster. So if you have the opportunity, try to watch one of the episodes. Valentin, thank you so much for sharing your time. We know how busy you are, and for us, it's a privilege to have you today.
Thank you, Mario. You can hear me well, isn't it?
Yes, we can.
Well, thanks very much, Mario, for your kind words. And certainly, it was a pleasure also to work with you, first at the Mass General and then at Mount Sinai. And we will continue to share, discussions and meeting together. It's a pleasure to be here with you today and to talk about a hot subject. And that is, I can go to the past, but I prefer to go to the future based on what has happened in the last couple of years. And I will be presenting to you a number of concepts that you might be intrigued by, and certainly I hope motivated. You know, about 10 years ago, I reached the conclusion that we knew more about health, that we knew more about disease than about health. And we began to investigate what is health, but with the most modern tools. And that is, this is what I'm going to be presenting to you today. And that is development and innovation in cardiovascular health. What is health? And is an age-dependent phenomenon, which we have. I'm going to outline for you our program. Basically, what we did is to begin to understand what is health at different ages. And this is the change that has taken place, at least in my own mind, over the last few years. We worked very hard in trying to understand the atherosclerotic process here in the bottom. Unfortunately, we always talk after an event or even close to an event. The question is, can we go earlier? And this has been the move in the last few years that we made, is to understand what happens before we get into the final critical cardiovascular event. So we have health in people between age 60 and 100, health in people between age 20 and 60, and health between birth and age 20. When I say health, I have to see, we have to investigate what is going on that we might prevent the final cardiovascular event. So we are beginning with a clean artery. Now, the technologies that we have been using are in the right side of the slide, and that is Imagenomics, that is new technology of imaging and genetics, the artificial intelligence, then new therapies which actually enhance the defense mechanisms that we have in health. In fact, if you are asking me about the pharmacology of the future, we'll be very much focused in enhancing defense mechanisms that we have in health. And finally, a cell that circulates in blood, which is a monocyte, it can tell us a lot, not only about our genetics, but about many, many aspects that actually are part of our biology. Today, I'm going to focus particularly on imagenomics, on the 3 H's that I mentioned. And let me begin by talking about people between age 20 and age 60. Now, if you look at what is the challenge at this age, to me, the challenge is I am developing the disease. And in this case, we talk about the number one killer, a disease of the arteries, or I am not. That to me is the critical question. Let me say how we can answer this question today at the population level. And here is where we are going to begin our discussion today, is about these people at this age. They don't have disease yet that is clinically apparent. Well, we go back to the conventional risk factors, and I always like to divide them very simply into 2 mechanical, which is obesity and high blood pressure, 2 chemical, which is actually diabetes, this is the pancreas, or high cholesterol, and then 3 behavioral, and that is smoking, a lack of exercise, and then a poor diet, not necessarily leading to obesity. The concept over the years has been that most of these risk factors affect the endothelium. And then when the endothelium is affected, cholesterol or LDL enters into the vessel wall. And this is the beginning of the atherosclerotic process. Even in people who have normal LDL cholesterol levels, for example, if they have hypertension or diabetes, still that LDL enters into the vessel wall. This has been a very, very significant concept over the years, but as you will see later, things are not so simple as they appear in the slide. So we said, if we want to know if one person has disease or not, silent disease, let's go into imaging technology. And one of my friends said, you know, we have fantastic technologies today. We can see the arteries inside with OCT. We have done a lot of work with OCT, but the problem is you can achieve with OCT maybe 1 in 1,000 people in the world. I'm not interested in that. I'm interested, can we make a change on health at the population level? So technologies like this, very sophisticated, are not going to give you the answer. So over the last few years, we developed technologies that are now going to be available very soon, which is externally, can you look at whether the arteries are developing disease? Well, we actually move into 2D and 3D ultrasound in looking at the possibility to have a sense of what goes on in the carotid arteries externally, in the main aorta, and also in the 2 iliofemoral regions. And what do we do with the coronaries? Well, we'll use CT for calcification, an indirect way. We developed this technology, and now this is going to be also absolutely automatic very soon, in which we will measure the amount of disease in cubic millimeters. At this moment, we are reaching that stage now and will be automatic. But let me tell you that we began by using this technology actually in 4,000 people, aged 40 to 55 years, in working people in a bank in Madrid. And this is basically what we do. We do cross-section, longitudinal sections, and then we follow these people for 20 years. So we have an imaging every 4 years. And here, for example, you have a very small plaque here, how it can grow. Well, with this, I will tell you the first finding was surprising. And that is, in these apparently normal people, the disease begins in the iliofemoral region. Not necessarily clinically, because the arteries are very large. This is why the coronary arteries actually appear clinically first. It's not because the disease begins there, but the arteries are small, and any degree of disease can cause obstruction, something very different in the iliofemoral region. Well, our first finding were of interest. What we have here are males and females, 4,000 people between age 40 and 55. Under age of 50, in males, 2/3 have already disease in one of the 6 arterial segments that I mentioned, to coronaries, to iliofemorals, aorta, or coronary arteries. And actually, you can see this is one of the 6 regions being involved, 2 or 3, 4, 5, or 6. And in women at this age, 50%. So the disease begins in early life. And I am showing you now below age 50, but I will show you later what goes on at age 20. So this technology is really giving a sense that when we talk about disease, better we pay attention what is happening before the event, because this is all cooking very early. But there is something else, as we published recently in 220, the disease progresses rapidly. Actually, in 4 years, 41% of these people have some progression of the plaques that we identify. And then what is important, in 900 of them, now what decided to do is positron emission tomography to address inflammation in the large arteries, and magnetic resonance imaging, particularly to address fibrotic phenomena. And this is what we are beginning to see, the bone marrow. Where the bone marrow comes on this? Very simple. These cells, where the cholesterol is deposited as a foreign body, come from the bone marrow. And then there is a war, and that is, there is a deposition of a foreign substance, is LDL, and the macrophages come in, and they try to absorb this oxidized LDL, actually, and if they do this, the plaque is transformed into a fibrotic lesion. And this is the end of the war. And this is actually what we are beginning to see now in a longitudinal study, that the so-called fatty streaks that were defined at autopsy may be the beginning of the disease. And this is when the monocytes, macrophages from the bone marrow get into the artery, and they take care of the excess of cholesterol. And the end result is a fibrotic lesion, but even more, calcification. When we measure a calcium score, this is a manifestation of healing. Certainly means has been disease, but is healing. And this is actually very fascinating. I am saying this because later on, when the excess of LDL really is such that the macrophages cannot take care, then the macrophages commit suicide. And this is what we call apoptosis, releasing cytokines and tissue factor. And this may be critical when the so-called vulnerable plaque leading to the final coronary event. The war is actually, the winner is the deposition of cholesterol being very abundant over the macrophages, that they cannot do the job. This concept of defense is very critical. Any foreign body in our body, a bacteria, COVID-19, etc., calls for a fight. And the fight comes from the macrophages in the bone marrow. And the war is who is the winner. And then this is exactly what we found in COVID-19 is actually happening now in the foreign body of LDL cholesterol that accumulates in the intima of the artery with the risk factors I mentioned. And here is just, the study is going to be published very soon. Actually, this is the bone marrow, how it lights up with positron emission tomography. And now you're going to see, and this is what we see in the artery. Very fascinating. We have a study now of 900 people with this technology showing how the disease begins and how the disease progresses. Well, here is something very fascinating. More risk factors we had of the 7 I mentioned, higher is the deposition or the inflammation. And here in blue is the iliofemoral region. Very expected, according to what I said, more risk factors, more inflammation, beginning in the iliofemoral region. And these are fibrotic lesions that we identify with magnetic resonance imaging in the 900 individuals, apparently normal between age 40 and age 55. Very interesting. And here is age. Older we are, higher is the likelihood of inflammation and of fibrotic lesions. So the first concept I want to present to you today is that cardiovascular disease begins early in life, is silent, unfortunately we don't know, begins in the iliofemoral region in about 75% of people that we studied, of the 4,000. And the risk factors and the inflammation are the driving sources that lead to the atherosclerotic process. And I mentioned to you the risk factors cause entry of cholesterol, LDL, into the vessel wall, and then the inflammation as a defense mechanism. Having said this, now comes an issue, and it's a very practical one. All of you have seen patients that come to you without obvious risk factors, and they have a coronary event. Sure, LP(a), maybe fibrinogen, maybe whatever it is, but I'm going to present to you two explanations that we found in the study in the 4,000 people that I mentioned. There was a group with a high risk of Framingham. There were at least, of the 7 risk factors, there were at least 4 of them. 2 or 3 risk factors, 1 or none. Interestingly, even with no risk factors, or with only 1, a significant number of people have already subclinical disease. This is what the colors show. The red color is more disease, the other color is less disease, 2 or 3 sites being involved, 4, 5, or 6. So, how is possible? What is the explanation? And this is fascinating. If you look at the LDL normal in the guidelines, they say between 100 and 120, you are okay if you never had any coronary vascular event, sure. But look at this is the amount of subclinical disease, unless we have less than 70 milligrams DL. So what we are seeing is what we call normal, based on heart attacks and strokes after age of 40, is absolutely abnormal when you look at the presence of subclinical disease. We found the same in hemoglobin A1C. If you go to the guidelines, the pre-diabetic says it's an alarm system. It's not an alarm system. A hemoglobin A1C we found between 5.5 and 6. There's a lot of subclinical disease already. And so with triglycerides, which are about 150 to 175. So what we are really seeing now is we have ignored the reality that the disease is cooking much earlier. And actually, what we consider normal with disease is completely abnormal by subclinical disease. And this actually is very fascinating, because this leads to a second issue. And that is what happens in the first 40 years of life. Okay, we already presented part of the problem is that what we consider normal is abnormal, but what about if we go to very early age? The Cardiovascular Study were patients or individuals between age 18 to 40 years that now have been followed for at least 40 years. We got hold of the data of all the risk factors that happen in these young individuals at this stage. Because in the guidelines, they don't care about this. The guidelines start at age 40. What is your risk factor from age 40 on? We went much earlier. And now comes the surprise. And this is what we found. The impact of LDL cholesterol in this case, for example, being in between age 0 and age 40, we were able to follow these people, certainly from age 20 to age 40. And what we found is the burden of LDL cholesterol impact could predict what happens at age 60, 70 in terms of cardiovascular events. and that is the most important factor of a cardiovascular event was not the risk factor profile at age 40, was the impact of the risk factors at a much earlier stage. This opens a field to us, and that is, and I'm going to summarize this here, cardiovascular disease is frequent without obvious risk factors. Why? Because we consider normal what is abnormal. The disease is already developing, and we feel very happy with an LDL cholesterol, a hemoglobin A1C, of what has been said being normal, and is not. But there's something else. What has been going on in the first few years of life has a huge impact into the events that happen later on in life. And this is the first 40 years. So this is open to us, and the issue that I'm trying to convey to you today, and that is what we have considered health, we don't understand it, and it's better we penetrate with new technologies as I am presenting today. Well, this leads now to the first trial that is going to be developed at young age, the PreCut Trial. This is a study that we are planning now in people between age 20 to 40. We consider abnormal an LDL cholesterol more than 70 milligrams DL. And then what we are going to do is to randomize these young individuals, 2,500, into active treatment in trying to drop the LDL less than 70, and then guideline-based treatment. You know what the guideline-based treatment is for young people? Please take care of the risk factors. That's what you will see in all the guidelines. It's atrocious. It seems to me we have completely ignored what goes on in the arteries during the silent stage. Well, the follow-up is 10 years, and the primary endpoint is progression of disease, as we have been doing in the 4,000 people that we are now year number 10 almost, no, year number 8 of the follow-up over 20 years of these 4,000 people. But you might be skeptical, and you might say, well, progression of disease not necessarily means are going to be cardiovascular events. Well, we have the data now, and we obtained this data very recently. Progression of disease means cardiovascular events. And this is the data. Actually, the data was obtained by the Bioimage Study. Actually, Mario may remember the study that we did here. And actually, we did it in New York, but these were patients or individuals between age 60 and 100 living in the Chicago area and in Florida. What we now have, the 12-year follow-up with the technology that we use. Now I am presenting carotid disease, and that is at time 0 when these patients at that age, not these apparently normal individuals, enter into the study. We look at the burden of disease in the carotid system. And now we find this absolutely can predict mortality later on in life. So more disease has progressed that we see at time 0. Higher is the mortality in the follow-up. So what we are going to do in our previous study that I mentioned is that with a secondary endpoint that are events, is 2 young people, but what we will do is we will put together what is the burden of disease of these people who have been randomized, let's say at age 45, age 50. And then we will look at this burden of disease. What happened when we went in the Bioimage Study? People who had that burden of disease, what was the incidence of events and mortality? And we will do a statistical matching. This is basically how the study is going to take place. So the next concept number 3, is cardiovascular disease not only begins early in life, but we now have a unique approach which is in subclinical state, and we use a much more strict, in this study specifically, of LDL cholesterol. And then we try to randomize individuals at that young age. Well, this being said, now let's go to the clinic. Let's go to the people you see every day. And let's see what can we do based on the 3 concepts that I presented. Well, the people of these 4,000 people, 2/3 of males have already subclinical disease and 50% of the women. What can we do? And these are now therapeutic approaches of modification of risk factor profile. We followed two approaches. One was individual. A clear example is in Kenya. In Kenya, is in a region of Kenya we are working with. There is a very high incidence of hypertension. Why? Because they keep the food with salt. There are no freezers, and they develop hypertension. This is the group, our group of investigators in Kenya. An individualized approach, and we have done this in two other studies. That is, you go to the individual, phone calls, take care of these, a very, very significant interaction. Let me tell you about this. It works. I will show you the results. Very expensive. The individual approach is nice in our practice. We have our patients and they come and we talk about the cholesterol come next year. Yes, but this is no more than 5% of the population in this world that have such interaction with us. What do we do with the rest? You can have an individual approach, but I will tell you, it's very expensive. We took a second approach, which is group therapy. And that is, you're obese, I smoke, can we help each other? And we have 3 studies, one in the island of Grenada, another in a town in Spain called Cardona, and another in 7 villages of Spain, which you have here. And what we did is we got a group of 10 or 15 people who were affected by risk factors, and they conveyed together, they interacted together once a month. And then we did this for a year, and every study we compare with normal controls. Then we say, you go, this is what you should do, go on. So the individualized approach versus the group therapy approach were always compared with controls. And we have 6 studies, all published now, and I want to give you the concept that we learned. Very interesting. This is actually a group therapy, but it applies to the others, and that is you intervene and everything is fantastic. You can look at behavior, cholesterol, weight, everything. Very, very good. Then what happened? The first 12 months, 2 years, fantastic, and then things drop. Why? As humans, we are not sustainable. This is the reality. But there's something else in the slide. Look, this is the control group. We told them at the beginning what they should do, and they do reasonably well, actually. You know what is a culture? When you use control people that are mixed with the people that you are intervening, you may have a good results with the controls. So what we have seen here in all of our studies, and I have more to present in a moment, is that actually, if you want to change health on individuals, you can use group therapy, much less expensive, with equal results that individual therapy, which is much more expensive. But the results are that it's not sustainable. It lasts for a while. You have a good impact. Certainly here, at this stage of 52 months, things are better than when there was the beginning, but there is a drop. So our hypothesis today is reintervention. And the reintervention will probably be exponentially better if you have been intervened before than if you are intervened for the first time. And this is the concept that is here, concept number 5, that if we try to address the problem I am presenting to you today, subclinical disease, is all beginning. Can we modify people? The modification is transient and needs re-education. And now this leads to a fantastic field, genetics. And this is the question. What is more important, the factors that I mentioned to you as risk factors or our genes? Well, we approach this. Very basically, we pulled together, we got together the ARIC study in the United States, the Malmö study in Sweden, our Bioimage study that I present in people between age 60 and 100, and the Boston Women's Health Study. And we decided to quantify genetics. How you quantify genetics? One way to do it is you pick up the 50 genes that have been very much involved in disease in the literature, and then you look at the number of mutations of these 50 genes in individuals that we are studying in these 4 studies. High risk, more mutations, lower risk, less mutations. And you do the same with the risk factors. Where were the findings? Very interesting. 3 important findings. First, both are independent. except in hypercholesterolemia, familial hypercholesterolemia, and diabetes type 1. So are two completely different pathways. Second finding. The second finding is if you have a high genetic risk, this means you are over. Nothing to be done. No, because most of these people have one or two risk factors on the right side that actually may be modified. In this country, for example, in people over age of 40, only 3% do not have any of the 7 risk factors I mentioned. So what we did, and this was published actually in the New England Journal, I think is later on, and if you correct, in these people are high genetic risk, you correct the cholesterol levels being high, you may reach a 50% reduction in events. So there is no excuse of a high genetic approach. Let me tell you about genetics for a moment. It's just at the side. My father had disease at age 40, a stroke. My brother had a heart attack at age 35. So my genetics are terrible. I'm sorry to tell you, not necessarily. Most of these people actually have the same acquired risk factors. You are obese, you smoke like your father, you don't take care of your high blood pressure like your father. So when we talk about genetics, you have to be very careful because the family history not necessarily means that you are in a high genetic profile. Maybe you are having the same risk factors that were acquired by your father or brother and so forth. This is what we found in the study. But the third most important issue is the so-called CHIP or CHIP mutations. The hematologists know very well what I'm talking about, and that is clonal hematopoiesis of indeterminate potential. What is really happening here is that the bone marrow, when it reacts as a defense mechanism against a foreign body, such bone marrow, the cells that come out, not necessarily are good cells to defend you. They may have a genetic problem. In fact, it's very, very common in the elderly population, in when one of the genes that is the motor engine of defense is not working. So here's a fiasco. The cells go into your defense and they are not working. And this may happen particularly as an important risk factor in the elderly. And that is not that there is too much cholesterol. Is the motor engine that it has to take the cholesterol out is not working. And one of the important genes is the TET2, one of the 50 genes that is important. These are macrophages of the bone marrow that convert the fatty streak into a fibrotic process. This macrophage is type 2. But there are other macrophages that come in from the bone marrow that they take care of debris of something that has happened, a heart attack, clots, vulnerable plots. And what they do, they clean the area, but in general, they clean too much, and this can lead to a problem. The Cantos study actually is very interesting. These were people with previous cardiovascular events. And what they do, they use a monoclonal antibody against interleukin-1, because the call from the artery to the bone marrow is made by interleukin-1. So why you don't prevent interleukin-1, you block interleukin-1, and then the devastating cleaning doesn't exist. Well, that's what TET2 is doing. TET2 is preventing this defense mechanism to go too far and not to make the artery worse. The cleaning is causing more rupture and so forth. So when the TET2 is actually mutated, it's bad news. The process of defense with macrophages comes in and is devastating. So now we are beginning to see that actually the study of Cantos, what you did is a monoclonal antibody preventing a defense mechanism, interleukin-1, that was too aggressive. This was the call from the position of cholesterol to the bone marrow. Today, can we make TET2 healthy through editing? That's an issue that is very fascinating. But what I'm really presenting to you is the new pharmacology of the future is going to enhance the defense mechanisms. This is what I'm talking about. And here we go back to the previous slide, but now we are in trouble. The patient has too much cholesterol, has not been taken care of. Why? Because the macrophages are not capable to do the job. There's too much deposition. Or because the motor engine is sick, in particular in the elderly. It gets there, but the mutation of the genes that are there are not capable to make the motor engine to work. What we have now is a big question. Is the acute coronary syndrome a syndrome of late apoptosis, of actually macrophages that cannot do the job because there is too much substrate? Or perhaps it's a process of CHIP, and that is the macrophages are there, but they cannot take care of the process because the genes of the motor engine are mutated. A big question today, a very fascinating question, but I'm presenting to you what goes on before the heart attack or the stroke. And now there's a big surprise here, a big surprise. We said that the risk factors cause injury of the endothelium, and then LDL enters into the vessel wall. In our studies with PET and looking at the bone marrow reaction, the bone marrow, and so forth, we had a big surprise. Obesity, hypertension, the metabolic syndrome. Do you know what is in red? They directly stimulate the bone marrow. So what we are beginning to see is that the risk factors not only may cause damage to the endothelium and then have cholesterol deposited, but maybe the same risk factors are asking for help, and they go to the bone marrow to already begin to direct cells into what is being deposited in the main artery. So I'm presenting to you important aspects of biology that occurs during health, and maybe the here is a rescue, and the same risk factors that are really causing the damage of the endothelium and the cholesterol deposition, they go to the bone marrow to ask for help. Very fascinating in terms of the biology of what goes on in the atherosclerotic process. So we have cardiovascular events. Either is an apoptotic process of macrophages that cannot do the job, or is the engine process, the chip that we mentioned. But then there is a second aspect, the bone marrow as a secondary to the vessel wall in terms of a defense mechanism from the same risk factors, or the risk factors only cause trouble on the endothelium. Maybe both. This is a very important question. So here what I presented to you are 5 concepts that have evolved from our studies in trying to understand health between age 20 and age 60. And the key question is, do I have disease or I not? If I have disease through imaging technology, let's look at the ephemeral arteries first. And this is what we are doing now beginning in developing countries. It's just with the device to look, because if the iliofemoral is showing disease, it's going to be extensive. And then something could be done. Group therapy, individual therapy, I am more for the group therapy because it's much less expensive, but the problem is it's not sustainable. The results are good, not sustainable. We have to redo. This is the concepts that I am presenting to you this morning. What is the challenge between age 60 and 100? The brain, cognitive function. And here we are getting now in this group here. And this is the study, the Tanzania study that we began in 2021. And this is the concept. Hypertension, hyperlipidemia, diabetes, etc. not only cause disease in the large arteries, but they also cause intimal hyperplasia in the arteriolar system of the brain. There is autopsy data showing that. So we began the Tanzania study, and this is the following. Individuals who have neurocognitive dysfunction are imaged to the large arteries, calcification, cardiovascular risk assessment, carotid plaques, iliofemoral, and we do imaging of the brain too. Amyloid presence with PET, or we can look at actually the flow of the brain with MRI. But all this starts with neurocognitive dysfunction. Here is the opposite. This is a second pathway. We start with disease in the large arteries, like carotid plaques. And then we do imaging of the whole system and certainly neurocognitive testing. It's a dual approach. Well, I will present to you now just a summary of what you are going to be being published in the next few months or so. And it's fascinating, the findings. are 5. It's like 5 concepts, but this is about brain disease. First, the risk factors cause cardiovascular disease of the large arteries, which translate into mortality. I don't have to discuss this any longer. Importantly, the risk factors can actually cause very, very succinct vessel disease, and that is trivial or subclinical disease, as I showed. But we have seen with magnetic resonance imaging that in hypertensive not treated, in diabetics not treated, in hypercholesterolemic not treated, in 79 people, actually we look at, and there is a decrease in the flow of the brain by magnetic resonance imaging. And we believe this is the microvascular disease that is seen at autopsy, which is a hyperplasia of the media of the arteriolar system, actually decreasing the lumen of the arteriolar system of the brain. But even further, and this was published a few weeks ago, we did uptake of the brain of glucose with PET is decreased when there is a decreased flow and when there is disease in the large arteries by the risk factors I mentioned. But even further, and you will see this published very soon, as the flow decreases and the metabolism and the uptake of glucose decreases in the brain, we have cognitive dysfunction. To me, a critical issue of senile dementia are the same risk factors that affect the cardiovascular system, the large arteries, but here they are affecting the small arteries of the brain. But even further, and we have already some publications on this, Alzheimer's disease. We believe that in Alzheimer's disease, the disease may be accelerated by the risk factors that I mentioned that affect the large arteries. May be accelerated, but there is more. We have now a mice model, a model of small animals that develops Alzheimer's, and amyloid actually is prothrombogenic. As the amyloid enters into the brain, may be small clots in the microvascular of the brain. So we now believe what Alzheimer's said 100 years ago. You know what he said? My disease is a vascular disease. Nobody pay attention to, because cognitive dysfunction, everybody got into the neuron, into the neuronal system, but not into the parenchyma or into the microvasculature. And what we are saying here is that actually the disease actually is complex, may affect the neuron with the deposition of certain amyloid and others, but at the same time, the vascularity, the vascular component may be important in the progression of the disease. And here I just want to know to present to you the concept. Risk factors affect the large arteries, but may affect cerebral perfusion. And cerebral perfusion may lead to decreased metabolism or uptake of glucose. And this may lead to cognitive decline. In Alzheimer's, may be the same thing, actually. May accelerate Alzheimer's. And in addition, in Alzheimer's, may be blood clotting in the very small arteries of the brain because of the amyloid. Actually, it's very interesting. We are now in the process, perhaps developing a trial on antithrombotic agents in people with family history of Alzheimer's, but we are going very carefully or very cautiously. But this study was not perfect because not the same patients went through the 5 stages. These were different groups of patients, and we developed the hypothesis. But now we are doing this longitudinally, and that is in the PESA brain study that we have, transatlantic study, is to follow individuals with risk factors from the very beginning, look at subclinical disease, cognitive function, and to follow with all the 5 stages that I mentioned, plus something else. In cardiology, we are all excited about troponins. It's a biomarker of ischemia. But do you know we now have biomarkers already of very minor ischemia or damage of the brain? And this is actually part of our project. So we are really moving from the heart to the brain. These patients that we see so often that come to us and say, doctor, you ask me lots of things, stop smoking, lose weight, treating this and that. You know what? I prefer to die suddenly of cardiac disease with a heart attack or a stroke and will be over. Well, with these patients, let me tell you, at the moment that I tell them, what about your brain? What about if I tell you that what you don't want to modify may affect your cognitive function? You will not even recognize the people you love, instantaneous response. Today, the population that we want to address risk factor profile with cardiac disease, if we want to be successful, I can tell you over the last year, I have already a lot of experience. If you talk about the brain rather than the heart, the chances of success are much higher because this is a chronic problem. They don't see as an acute death. It's a chronic problem that they are very afraid. So the population today are much more sensitized about the brain than about the heart. They consider the heart sudden and death. They consider the brain chronic and disturbance. And this leads to the final comment that I want to make in the last 7-8 minutes. What about between birth to 20 years? Well, if you pick up anything from my talk today, this is the most important one. And that is what we have been missing with all of this. You already got the feeling that we are missing a lot of what goes on between these early stages. This is what we are talking about. Primordial prevention means that no risk factors. You don't allow them. Primary prevention is there are risk factors between age 20 and 60. We are trying to prevent them to go further. Well, I began working with Sesame Street, the television educational program a number of years ago. Are not here too much now, are more in developing countries. I remember my children actually watching this program. Let me tell you what happened. Cookie Monster used to eat cookies 7 days a week. One of the main things that we were able to really convey is to eat cookies 1 day a week. And children began to ask why. And you know what? They were so interested, they became interested in health. Now, this is actually was the takeoff of the program that I now have with 50,000 children around the world. Very basically, this is the concept. At young age, between age 3 to 6, which is actually the goal of Sesame program, is this age, the number of centers in the brain is very small. So anything you tell a child is a store, and it comes out when you're an adult. Look at your behavior today. And you will remember that great part of what you do is the environment that you had between age 3, 4, 5, or 6. Later on, things are much more complex. You are an adult now, lots of centers. Somebody tells you something and it's a chaos. You don't know if you retain that or not. There are too many things going on. So the best thing to do is to get into this young age and infuse to these children that health is a priority in their lives. And this is actually what we did. And we had 5 projects, main projects. The first one, and actually what I present to you today is all published, and so you can go into the publications. And if something is not published and is in press, it's there already. I don't like to talk about things that are just coming out as just from what we believe, but there is no data. 5,000 children, some from Bogota, Colombia, was a middle kind of socioeconomic status. About 2,000 came from Spain, higher or more than high average socioeconomic status. And actually it's about 1,000, near 1,000 from Harlem, New York, low socioeconomic status. Results fantastic. What we did is 60 hours of education over 6 months, how the body works, healthy food habits, physical activity, and how to control the emotions. We prepare these children about their future. When they are presented with alcohol, drugs, and so forth, they are now trained to say no. Results, spectacular. This is all published. Point number 2, the results were less spectacular when we follow these children for about 10 years. This is very good at the beginning, 2, 3 years, excellent results. What happens afterwards, they lose a lot of what they learn when they are age 10, 11, or 12. This is what we learn. We start at age 3 to 5, not sustainable. And now comes the third project. We have with 50,000 children. Do you know what the hypothesis is? The same than in adults. The re-education later on will be exponential benefit. So basically, we have here children of different ages, but let me present to you something very succinct that you will understand. A child was educated at age 3 to 5. It loses part of what it was educated, you know, the knowledge, attitude, weight reduction, so forth. And at age 10, 12, it seems has lost some of this. What we do is we reintervene this individual at age 10 to 12. And we compare with another one that starts for the first time at age 10 to 12, was not intervened before. And our hypothesis is like in adults, that the reintervention will have exponential benefit. We don't know, but you can imagine we are dealing with 50,000 children around the world, all randomized in different ages and so forth, learning a lot about what I consider is going to be the key of the future, and is early education in terms of health, rather than what we are doing now that is too late. This is project number 3. Project number 4, we are starting in New York now in the 5 boroughs. The socioeconomic status differences in the Bronx, in Staten Island, Queens, Manhattan, etc. We are looking at different socioeconomic aspects here and see where we are most successful. We have preliminary data with the 5,000 we mentioned before. But most importantly, we want to validate what makes a good teacher. What teacher gets motivated? If we are going to go into young children, you need to have the teachers who convey what I'm presenting to you today. And that is the modules, the 4 modules I presented over 60 hours, 6 months. You have to have good people. What motivates the teachers? But we are doing more than that. We are going to look at the pollution in New York. We have this through NASA. We know every place, every corner of the Bronx, etc. We know the pollution there. And we are going to see what is the effect of pollution in these children. The microbiome, very important. And how immunologically these children react when there is something like pollution or the environment of smoking, etc. All of this is the New York project. And it is very fascinating in children. But then we have another project at the same time. 2 villages, the Cardona village of Spain I mentioned before, in Sayen, 2 mining villages, they are on recession. And in this one, we are going to do everything I presented to you before today, in the elderly, the adults, and the children. And here, this serves as control, 4,000 villagers, 4,000 people in each village. We started this project and it's going on over 10 years. Can we change a village by going at different ages in the way I presented to you today, that we are learning about health? That's what we are doing. And this is project number 4, the New York project and the project of villages. See if this can be extended then to towns or cities. We'll see. And this is actually, interestingly, we learn in our project that culture is essential. These children, in the school, we teach them what to do. When they go home, and who knows what goes on there, the parents not necessarily feel like the children. So the children are more successful in changing the habits of the parents than the parents changing the habits of the children. This is what we learn. So we said, why we don't create a culture of the family? And this is the project I'm so excited, is the so-called Family University of Health. And that is what we do is we get into a community, maybe a community of investigators, maybe in a hospital, maybe in a corporation. And we enter into the family of these people who work in these places, the grandparents, the parents, the children, and the grandchildren. With the 4 modes I presented to you here, in over 1 year, this is what we do. 4 aspects that I presented: how the body works, physical activity, the best nutrition possible, control your emotions. 2 weeks each. And then we do more, a little bit more mature, the same thing. And this is all of a year. But what is most important, the program is not exactly the same on the parents and in the children and grandchildren, are adapted to their age. But they are all part of a culture. And at the very end, we plan to give a diploma. Dr. Rooster is the Muppet of Sesame, and that is the diploma of the Family University of Health diploma. We are very excited. Corporations are excited. Groups of people are excited. We are starting this in the month of July of this year. The summary of my presentation today. Later we start, more costly, less benefit. This is what we have been doing. Let's investigate much earlier and earlier. And here the potential benefit of addressing health before disease, perhaps at the subclinical stage, is much less expensive and of much more benefit. And this is basically what I presented to you today. And actually, if I can summarize, I presented to you 15 concepts. 5 concepts you remember of people between age 20 to 60, where the challenge there is actually, I am developing the disease, and then what to do about it. I presented to you 5 concepts on the brain, which is a step by step with the technology. I didn't go into the details, but now we are doing this longitudinally, including Alzheimer's disease. And finally, I presented to you 5 projects in children at different ages, different expectations. Now we are in towns, we are in the culture of the family. 5 projects. So basically what I decided to do today is what we have done in this with the data evolving between 2020 and 2022 and trying to project what I think is going to be the future. And the future is going to be paying much more attention in early ages and much more attention in people who are apparently healthy, and then trying to really use all what we learn at those particular stages in life, and then probably will have much more impact than what we are doing today, is starting too late. Well, anyway, thank you very much for giving me this opportunity. As you can see, I am quite excited. Many of these things I am presenting will be seen by my grandchildren, not by myself, but we are really working into what I consider is the root of the problem. And that is what develops at ages that we think nothing is happening. Thank you.
Thank you. Thank you very much, Dr. Fuster. It's David Warsheimer. Can you hear me?
Sure.
Hi, Dr. Fuster. Nice to see you again. So, here in the United States tonight, we had the State of the Union address. And I think most of us would agree that, what we just heard is really the paradigm for how to approach that. We obviously have a lot of questions. Dr. Fuster's talks are always fascinating. I think the way we'll handle it is, I think it was particularly fitting that Dr. Fuster ended the last part of his lecture today with a focus on the future. And in the introduction, Dr. Garcia alluded to Dr. Fuster's prowess as a clinician. But for me personally, spending many years of my career at Mount Sinai, I think it's very fitting, at least the way you ended the presentation, which is the focus on the future. For me, Dr. Fuster was my teacher, remains my teacher, my mentor. There are many fellows in the room here, and when we round, the style of rounds that we sort of try to aspire to on the consult service is really the legacy of what I learned from you as a resident, many years ago in Resident Report, where we went to the bedside and just as you did today, asked simple, straightforward, piercing questions. What is this? What does it mean? And what does it mean for the future? So I think for the first question, we're going to ask Dr. Leandro Slipchuk, who's our Director of Imaging, and then we'll move to some questions by the fellows. Leandro?
David, first of all, let me give you thanks for your comments. I mean, you have always been so nice person, from ever, and I really appreciate the comments that you made. I make a proposition, if you agree, and I will be happy to. Why we don't have another meeting in the next few weeks and you have 1 hour of questions, all of you, because the field is so dense that we can talk about minutiae here or there, but I will be happy to do it, very happy actually, because I feel that particularly for the fellows and the young people, the topic that we are discussing is so important that I think to have another hour, and you decide, Mario, whenever you want, or David, we can have this getting together in the next few weeks. And then we can have, because now you can have 1 question or 2 questions, but I don't think I feel happy about to be too superficial on something that is so, it requires a lot of thinking. What do you think, Mario?
I think Mario had to step off. He was in another meeting, but I'll absolutely arrange that. Should I call Marta or what should we call?
Whenever you have either morning report or whatever, you pick up, have 1 hour with you guys or 45 minutes and just going over this. This is a very, very new field that for the young people is going to be absolutely crucial for those of you in the future. And I will tell you even more. I am in a couple of committees that they're looking at reimbursement of the future in the cardiovascular field. And the reimbursement is going to increase significantly towards the preventive side compared with the interventional side. This is a movement that is beginning at this time. So what I'm really saying to you that the importance of what we can do before the disease is out is just from the economic point of view is beginning to be very, very important in Washington. And I think I would like to rather go into more detail. And I hope you, David, you agree with that too. Then let's have a discussion, all of us, and I think it will be much more meaningful.
Thank you very much, Dr. Fuster. This was amazing. Thank you for accepting the invitation. And it's always so motivating to hear your talks. And I think as you show the group therapy, we all need a little bit of Valentin Fuster therapy to get the motivation to do some more extra work. So I'll do two brief questions, and I think it's great if we can set another meeting for the fellows and to have more questions. First, as you showed the risk factors and the limitations from the full cohort equation, the question is, should we still use this equation or should we look for at a subclinical atherosclerosis?
No question. I think subclinical atherosclerosis first. That's the disease. What is a most important risk factor that to understand what is the burden of disease of somebody who is developing? But then you have to deal why is developing. So you have to really do the risk factor profile. But to me, what we are seeing actually in all the studies with imaging is that the highest predictor is imaging, I have to tell you, by far actually. And that is the amount of subclinical disease. I think what we will have now that we will have probably within a year all automatic, we will be able to just quantify what I presented to you today in cubic millimeters. And we will start in the iliofemoral region, because if you see disease there, you can already predict the trouble.
And the second question is, how do we get these to patients? When I train in Cedars-Sinai, people could cover it monetarily, but the insurance doesn't approve it here.
I can tell you, I am already planning in all the personnel here at Mount Sinai to do that. So our plans is to expose to large groups of people. And actually, I believe should start in places like ours. For example, in Madrid, you know, I direct the Center of Cardiovascular Investigations like NHLBI, and it's a group of 400 investigators. I plan to start the family project with those people, with investigators. And so I think we will become sensitized if we do this for ourselves. So my advice is all of this that is evolving, the best place to start is in a health system, because this health system can sensitize the public afterwards.
That's great. Thank you so much. David, do you want a question by the fellows and then we go by the rest?
Yeah, I'm just, Dr. Fuster, while Leandro was sort of checking, I'm just checking our calendar. So April 5th, which is 1 month from today. So I don't want to let you go.
I will write this down, okay?
Okay, I'm going to call Martha as soon as we're finished here.
I will give you an answer later, okay?
Okay, April 5th, same time.
Yeah, I think it's getting late for all of us. Look, I appreciate very much. It's a pleasure. And it is wonderful to see David, Mario, and others there. And let's continue to interact. It's a pleasure to do it. Nice talk.
Thank you so much.
Bye-bye.